Ladies and gentlemen, welcome to the Royal Statistical Society's fourth event on evidence sessions on COVID. First of all, let me apologise to you for, and particularly to people online, for the fact that I have started a quarter of an hour late. A previous session overran slightly. So first of all, those of you here, it's delightful to see people in person. And this session is part, as I said, of four that the Royal Statistical Society has held to start a discussion amongst statisticians and colleagues about issues around statistics and data, and of course evaluation that arose during the pandemic, aiming to identify areas of consensus, but also questions that we think merit further investigation. So we identified four key areas where we thought there were questions to be asked. The first evidence session was on government communication during the pandemic. The second on statistical resources available to the government, data resources and personnel. The third one was on how evidence and decision-making informed policy. And this, the fourth and final session, is on the evaluation of interventions and policy during COVID. So the questions for this particular session are these. How are risks to successful evaluation, such as low participation rate, biased comparators, weak performance monitoring, delayed transparency, how are those risks best managed? Which COVID health policies needed evaluation? Because not all policies do require evaluation, and so who decides, and are there some criteria? And the first of our speakers, and indeed also Teresa, will address that second issue. Thirdly, how are prior beliefs formulated about the likely impact of public health policies during COVID? And were those prior beliefs really plausible, grounded? Did they come via modelling, formal elicitation, or however? We know about randomised controlled trials of medicines and vaccines, but what are the barriers to randomisation when evaluating non-pharmaceutical interventions, such as how to encourage people to adhere to self-isolation? What were some of the benefits that evaluation brought during the pandemic, and what were missed opportunities? And in particular for the Royal Statistical Society, how can statistical science help us to deliver more robust policy evaluation in the next decade? So those are our four questions, our five questions, and the speakers on the panel with me are Professor Max Palmer, the Director of the Institute of Clinical Trials and Methodology at University College London, who in his theoretical work has dealt quite a lot with platform trials. Professor Dame Teresa Marteau, Director of Behaviour and Health Research Unit at the University of Cambridge, but also a member of SAGE. Professor Tim Peto, who's Professor of Infectious Diseases at the University of Oxford, and co-led a schools-based randomised controlled trial. And online, we will have Isabel Oliver, Interim Chief Scientific Advisor at the UK Health Security Agency, who was the lead for the Stop COVID randomised controlled trial. And again, online, Professor Chris Robertson, Professor of Public Health Epidemiology at the University of Strathclyde, and affiliated with Health Protection Scotland, who has dealt with a lot of the modelling work in Scotland and also the evaluation of effectiveness of vaccines. So those are our panel. The running order is that we will have these four sessions, a joint session between Tim and Isabel, and then there will be some questions amongst the organisers. Max Palmer, as well as being our first speaker, is co-organiser of this session with the panel, about 20 minutes. And then we will go on to a series of 2-minute contributions. The 2-minute contributors do not use slides. We will have, first of all, we'll invite those who are our in-person contributors and then go online to try to minimize changeovers. Okay, this, I should also mention that there is no fire alarm expected this afternoon, and so if you do hear one, please make your way safely to the exit behind or through this door. Finally, at the end of the contributed sessions, we will then have about 25 minutes for questions from the audience. And so without further ado, I'll ask Professor Max Palmer to set us off. Thank
you very much, Sheila. So for those who don't know me, I come from the clinical trials arena. Let's see how these. Just page down.
Yeah, sorry. That one.
Which one? This one. This one. Okay.
Yeah, sorry.
So I come from the clinical trials arena. So when thinking how to approach this, I thought I would go back to first principles, which is always a good place to start when you're thinking about how you might evaluate both in any intervention and the issues that might raise in a particular situation. So the place I started was that actually, if you look across interventions across the piece, whether they be medical or policy interventions, we know that many, if not most, interventions don't work. And there's a big failure rate for pharmaceutical interventions. There's a big failure rate for complex interventions in behavioural science, and so we know that's the history we have. So there's no reason why policy intervention should be any different. So in thinking through that, the first question I think we need to ask ourselves: is there a political will to evaluate a policy when there's a reasonable chance that what they've done, if you're assessing it in retrospect, what they're going to do there's a reasonable chance it's not going to work? For many policy decisions, the answer to that might be no. And so we have to go into this, I think, understanding the real politique of it, and we can discuss whether you think the answer is indeed no for many policy decisions. If it's yes in some instances, or a number of instances, and perhaps they're the instances where Matt Hancock just speaking gave those 3 instances where you've got the clinical trial space, where you get quite a well worked out way of getting an answer. You've got the areas where you really can't do evaluation or don't want to do any evaluation in any way, but there's a middle space where you might be able to do evaluations. If we're going to do evaluations, we know that the primary outcome measures need to be short-term, because we can't have long-term outcome measures for these policy decisions, either to inform the policy decision or to be able to change the policy, which has already been either partially rolled out or is going to be rolled out. And we also need to launch that evaluation quickly. We can't take months and months and months or years designing that evaluation. It's not going to work, is it? So those are all constraints that we have, I think. And some questions that we might want to ask ourselves at the beginning of setting out on this road: is the policy decision big and uncertain enough to justify evaluation? Can it in fact be evaluated? You could argue that the lockdown example that Matt Hancock gave, that was very difficult, if not impossible, to evaluate in a sensible way, in a sensible time frame. Is there a relatively short-term primary outcome measure which you can target, which will help you make a decision? And as best as we can judge, is the result of any evaluation likely to be available in the timescale to influence or change policy? If it isn't, then there really is little point in evaluating it, unless you want to go back and say, well, actually, we didn't do the right thing, which is unlikely to be a vote winner, I think. And finally, I guess 2 other things that we need to add: is the signal likely to be large enough to detect the design that we're proposing? Especially if a standard RCT is unlikely, a randomized controlled trial may not be like the traditional one, may not be possible. Well, given all the confounders, is the signal that we're looking for likely to be large enough to be picked up? all of those questions we should pose. I just put at the bottom here some sort of step wedge design, a cluster randomized trial may be suitable for a number of policy decisions. What could we do now? Well, what we're doing today, I guess, is reviewing some of the major policy decisions during COVID and seeing which have been evaluated and what they led to. So that's a good thing. And how we might learn. But perhaps what we also could do is review those in some sort of systematic way. We don't have to be comprehensive, I don't think, but some sort of systematic way, those which were not evaluated, and consider whether evaluation was even possible, whether it was desirable. If not, why wasn't it? And was it realpolitik that was driving this? Or was it really just impossible to do in the timeframes that we were setting up? And if yes, how might we have designed such a study? Because that will lead us to learn about how we might design studies in the future, either within this pandemic or other pandemics. I also like to finish by saying that that because of the need for speed and efficiency in this arena, and that can't be underemphasized. We need to move at incredible speed and with a great deal of efficiency in this arena. So one thing we could think about doing is, once that we've reviewed that evidence base, can we set up some protocols such that for either the subsequent waves of this pandemic or the next pandemic, we have some evaluation ready protocols? Is that possible? Even in outline form, I think that's worth exploring. And can we develop platforms in the same way we have done in the clinical trials arena to evaluate a number of policy decisions? And in this country, actually, we're very, very good at observational studies. We do a lot of observational studies incredibly well. Is there something that we could build on the back of those to have evaluation-ready protocols that would allow us to assess a number of policy decisions? I'll stop there.
Wonderful, Max. Thank you very much. A very succinct introduction also allowed us to catch up a little bit of time. Now I'm going to pass over to Teresa.
Thanks very much. My answers to the 5 excellent questions that we've been set is informed by my expertise as a psychologist and behavioural scientist, as well as my experience outside of and during COVID-19 as a participant, particularly in 2 subgroups of SAGE. And I was also independent chair of the Science Board for the Events Research Programme. The first question, I think that there are 2 ways in which we could mitigate some of the risks to successful evaluation. First, having teams that have evaluation expertise and experience that are conducting the evaluations. And that, you'll be pleased to know, should include statisticians as well as experts with design and content expertise. Too often that did not happen with policy evaluation. It would also be useful to have a set of principles. Here are 4 principles that we included in a SAGE paper that was a science framework for the events research, events research program, in which we touch on the importance of designs, which Max has already mentioned, that optimize the ability to draw causal inferences, RCTs and beyond, the importance of robust measurement, and adopting principles, ethical principles, as well as principles of open science. Which policies should be evaluated? 2 possible criteria. First, spend. Where there's a large budget, and for NHS Test and Trace, not all of it was spent, but there's an indicative budget of £37 billion, a robust evaluation plan should be part of that programme. It was set up without such a plan, and as commented by the Public Accounts Committee, a lot of performance data were published, but it wasn't possible to infer an estimate of effectiveness. My second criterion would be the significance of any policy in achieving core aims. And I would suggest that during the pandemic, there were at least 2 core aims of any policy, which was to reduce transmission. And one policy that was core to that was financial and other support for self-isolation. I'll come back to that policy, but that was introduced. There was no robust evaluation plan. And reducing health inequalities. The vaccination rollout was important in terms of the potential to optimise uptake in all social groups. Again, there was no robust evaluation plan. Priors or expectations, to those of us who aren't statisticians, can be formulated using a mix of methods, of which modelling and formal elicitation are 2. I would also suggest we could add to that rapid reviews of existing evidence. I think there's a need to build on the methods that were being developed during what's been described as sort of tidal wave of evidence, which is to be applauded during the pandemic. But we need to be able to collate that in order to be able to use it. And so to continue with the methods that have already been started, using automation, crowdsourcing for use, not just during an emergency, but outside of that. 2 barriers to randomization, which I think are linked. The first is that evaluations, certainly of policy, weren't conducted by teams with evaluation expertise, which meant some of the teams didn't have statisticians, design or content experts. And I think that that reflects what I consider to be a weak and failing system of policy evaluation across government. And it was into that context that we went into the pandemic. So we got good government guidance in the green and magenta books, and those are regularly updated. But that guidance most often is not followed. So the National Audit Office in December of 2021 estimated that only 8% of major spending projects had a robust evaluation plan built in. And they described in their report in 2013, of which 2021 was a follow-up, a lack of political engagement in evaluation. I was sorry I didn't get my opportunity to ask the Secretary of State about that, about the extent to which that was his experience too. So lack of political engagement in evaluation and low capacity across Whitehall. Of course, there are many benefits. I just want to highlight the 1 or 2 benefits from one of the programs, so the Events Research Programme, which I think was the largest non-pharmaceutical policy evaluation, certainly in the UK, during the pandemic. And that was estimating risk of transmission at large-scale events, ranging from, I don't know why I put this at 2 ends, football and opera. I know that football could be an opera, and opera can be football. And I want to particularly underscore the role of the chief scientific advisors at DCMS and BAYS, who are absolutely key to that happening. So just to give you a flavour of some of the data, carbon dioxide was recorded in multiple places at live events as a proxy for ventilation. And so what this allowed us to see was a quantification of the variation in ventilation within a stadium. And if you can see, so the top 3 are all taking place in the same venue, which is Wembley in the outdoor arena. That would happen. Whereas further down, we've got Wembley Arena again, but in indoor areas. And you can also see that there's a difference between the mean and the maximum. And that's telling us that across time, this is changing at different stages of any event. Missed opportunities, I've already mentioned 2. And importantly, financial support for self-isolation in the lowest income households. SAGE advised in the middle of September that there should be urgent provision and evaluation of financial support to the lowest income households so that they would avoid the loss of any income. And that was both to realise the extraordinary investment in NHS test and trace and also contribute to economic recovery. And the government, a few days later, I don't know that it was linked, but they introduced a different policy package. So there was a fixed amount, £500 for those eligible for benefits. And what we didn't recommend, fines of up to £10,000 for not self-isolating. This wasn't evaluated. I'm sure some people were unable to self-isolate. It might have had no difference. My concern is that it had the potential to make things worse, to reduce self-isolation, because certainly there are reports of people who wouldn't go for testing with the prospect of a £10,000 fine. Vaccination rollout, SAGE predicted, based on what we know from other vaccination programmes, lower uptake in some social groups, predicted with high confidence. When the government rolled out the vaccination programme, there was no evaluation plan in which they could have compared different ways of rolling it out in order to mitigate the predicted low uptake for some groups. And what we have as of April 2020 is a vaccination rate, a mean in the adult population of 74%, but just taking areas of deprivation, it ranges by 30 percentage points from 59% in the most deprived to 89% in the least deprived quintile. Had different interventions been evaluated, it's potentially possible that that gap could have been lower. So how can statistical science in the form of statisticians, as well as the Royal Statistical Society, help? I would encourage those with statistical science skills to work with Go Science, the policy profession, and any other credible group that is minded to strengthen what I'm considering to be weak existing systems of policy evaluation for all three stages of policy making. If you know your Magenta book, and I can see a few heads nodding, they identify the three stages. First of all, the use of evidence and evaluation for policy design, the monitoring during implementation, and critically adjustments when a policy is off course, and then the outcome evaluation. For that to work both in and outside of emergencies. And without prejudging this work that I've yet to hear anybody saying they're going to start, but if you are, I'd strongly encourage, I'm very happy to join the team. Two characteristics that I would see in a strengthened, I'd recognise as part of a strengthened system would be required. So not just guidance, which, as I've already said, is mostly not followed. And secondly, a system that's transparent. So all three stages of policy making, one would see the documents published so they're open to public scrutiny, accountability, and in that way we could turn to more effective policies. So that's a snapshot of some of my responses to the excellent, I was going to say 5 questions, but has anybody else noticed that can statistics count? Because 5. Anyway.
Thank you very much, Teresa. Now we're going to hear from Tim Pito about the background to one of those important cluster randomised trials that was conducted rapidly with some record linkage in the background. This work has been published in The Lancet, but the Lancet paper, I'm sure, doesn't go into detail about the difficulties that there were in setting it up.
Well, thank you for letting me talk about this. 5 minutes is going to be a bit of a rush. My background, I'm an infectious disease doctor. In fact, I'm a sort of clinical trial person. I've worked with Max Farmer's units for years and sort of know about clinical trials, and that was partly the reason why doing this was quite an interesting experience. That one. So, quick background. We go back to January 2021. What we were doing was screening pupils and quarantining them in bubbles, causing chaos in schools but preventing transmission. You can be either optimist or pessimist about this. Huge division in society about what's good or bad. And 2 departments got together to do a trial, and they did the first protocol, and they came to me and said, look, we've got it all organised, we've got the manpower, we can manage the trial, we can analyse it. All we want is a clinician to front it up and make it look okay, kosher. Nothing to do, just do it. And I'm a nice guy, and I'd done lots of that for flow test work, so I said yes, thinking I could do that on the side. Very quickly, well, I did a lot of work on the redoing the protocol, but leaving that aside, that was January, and they wanted the answer by the end of June. They wanted the trial started and completed and published by the end of June for policy statements before the end of term, the summer term. That was the deadline. I said, okay, 200 schools randomized, controlled schools, intervention schools. I'm going to have a comparison arm called the controlled schools, new idea. And there were three outcomes, two major outcomes. Is this a safe thing to do? That means daily contact testing. You know about that now. So you can be released on daily testing and not quarantined. Is that safe? And then lastly, does it improve attendance? And there's a little bit extra. How often do contacts actually, of an index case, get the disease? Now, how do you out those outcomes? Well, we were totally naive, and we thought the schools would give us data. It turned out the schools were completely useless at giving us data. Some of them wanted to, but they didn't manage it. So we had to change horses halfway through and completely abandon getting data from schools. We got it from test and trace. So we wanted to have this. It was very difficult for the Department of Health and Education to understand. We wanted the ascertainment of endpoints to be equal on both the control and the intervention arms. And the second thing they didn't understand was the intervention shouldn't interfere with the ascertainment. So we went for test and trace for asymptomatic disease. We got data for COVID-related absences. We thought we'd get it from the schools. Some schools said, no, I'm not going to give it to you. Just refused for lots of different reasons. So luckily, we went to the Department of Education. They got them a different method. And then we managed to get some idea of immediate contact index cases by doing what's called research PCRs. The children would also do 2 PCRs over 7 days as a research thing, and they did not get the result until the end of the outbreak, so the results did not interfere with what happened. And that was just a background. Cluster randomized trial, individual consent for the research PCRs, but the schools gave consent for being in the cluster. To be in the trial. Obviously, cluster randomization, the parents did not give consent for that. And then we have a trial protocol done by the PHE Ethics Committee. Interesting. Local public health officials were involved, the public health doctors, for oversight of safety in schools. And then we got some independent committees, as you'd expect. And we were blind to the data during the study. And the results, well, it turned out that two things. First of all, very little transmission in schools from the index cases. And basically, daily contact tracing was safe. And I'm not going to go over to that. But it was basically after that, there was no more bubbles. Gone. Good or bad. Now, what were the challenges? It's my main purpose of the study. It wasn't, because it was done in pandemic time, could not be subject to the usual peer review. There wasn't time for that. And the departments didn't even think about that. And I mean, there's a little group called TIAB, where people look at this a little bit. All three of us are on this, but it's pretty sort of superficial compared to proper peer review. And in a certain sense, I was the person who was peer reviewing the first draft. But then, of course, I became part of it, so I was no longer independent. But there was a bit of movement on this. They felt ownership. It was their study. They're like a drug company with their drug. They did not want to let go of any of the control of anything. They were absolutely mortified that I said, this independent study, you're letting go. And they didn't like that. And the other thing which was a real problem, I couldn't get a clinical trial centre to work in real time, pandemic time. Impossible. And they wanted to report immediately. So that was a real problem. How to do it properly without the normal infrastructure. They had no idea. This is exactly what Hackard was saying. Some of them were highly intelligent, some of them were numerical, not just PPE, some or classics, but they did not know about clinical trials. They didn't know about control groups. The analysis team in the Department of Health had never considered how to present results in 2 columns control intervention. I said, you've got to have 2 columns of results with each outcome with 2 answers. Yeah, they didn't understand that. The second thing is they thought they didn't understand intent to treat. So the schools went in, the people who went to consent to schools didn't bother to say that if you say yes and go in, you're going to get randomized. And if you get in the wrong arm, you mustn't drop out, in a sense. And about a quarter dropped out. And then we had to go on following them to get intent to treat. And that was interesting. We were not involved in the people going to school, the promotional company. We did not have anything to do with the contracts that were given. And I did not know until the end that they were given a hard end date by the Department of Health to say you're going to stop the trial and sack all your workers, end the contract. And I was suddenly told, you can't go on another week because they've gone. Quite interesting. Schools, of course, my mistake was to think that schools were like hospitals. Hospitals understand trials a bit. Schools had no idea. Honest, nice people, but they didn't understand anything about trials. The politicians were highly interested in the results, and we were asked every week to just give us a hint how it's going. And my concern was I didn't want to get involved about minding. There was huge antagonism we had about today. People feel very strongly about these things. And some people didn't have confidence in our ethics committee. Ethics was a problem. Public health doctors were a problem because they wanted to be part of it and weren't. So to create a proper independent system was really important. Keep the departments away. There was only me, Bernadette Young, who's my trial doctor, I know very well, works with me, and David Ayres, statistician, who did this. We discovered we had to work for 4 months, full-time, all the time. And we met the team every morning, the schools, we met full-time meetings to keep people at bay. And we had to do difficult analysis plans to adjust for poor adherence. Sarah Walker was critical behind the scenes, wasn't involved, but was totally involved. Catherine Fielding, the DSMC statistician, really important. And I had to remind the department that I didn't mind the result. I wanted the right result. I didn't want to mind what the result was. They minded. I didn't want to be put in the position of minding. And we were a close-knit team, and the independent committees were critical to keep us going. And we had an enormous amount of luck that actually worked.
Yeah, perfect. Thank you, Tim. It's a fascinating story. Now we have the changeover to Isabel Oliver, if we can manage that, who'll give us the background to the Stop COVID trial. Isabel, welcome.
Thank you very much, and apologies for not being able to join you in person. First of all, huge thanks to you all for organizing this event and inviting me to participate. This is an area that I'm very passionate about, so thank you very much. The questions are really rich, and there's so much we could talk about. So I'm going to just share, if I can, this doesn't seem to work. Some of my thoughts, starting with, from my experience during the pandemic. As Sheila introduced me, I'm Interim Chief Scientific Officer for the UK Health Security Agency. Previously, I was Director of the National Infection Service in Public Health England, and I also had other roles in Public Health England. So my personal contribution to the pandemic has been extensive in many different ways, as you can imagine. But just thinking more broadly than the pandemic, so in health protection, we often need rapid evaluations, and this can result in pressure or inertia for suboptimal evaluations. What's even worse, in the past, I think we have suffered from an approach that was very much about response and implementing interventions without necessarily considering evaluation. And we've got plenty of examples of that where, let's say antibiotics for decolonizing people with certain bacterial infections have become standard practice without actually an evaluation, when one could have been done when the threat or the issue was first identified. One of the issues, I think, is that there are different views on what a successful evaluation is. And this is not a philosophical point. I think it links a little bit to what Tim was saying, that what so my background is as a medical epidemiologist, what we might think a successful evaluation is one that's robust and reliable, is not necessarily what our policy colleagues are thinking. They're just thinking that, they might not think of the same robustness as we are. So there can be a miscommunication there. For rapid evaluations in health protection, we often rely on routinely collected data with all of the limitations that has, including, missing data, misclassification, confounding, and so on. And participation rates can be low, although one of the good things of the pandemic is we actually saw increase in participation and engagement with research, at least in the COVID sphere. There is something about model-based evaluation and thinking about how do we make sure that we've got robust parameter data before those evaluations. One thing that I've been quite keen to do in the past is strengthen the reporting and publication of outbreak investigations in a way that allows us to extract parameter data that can inform those models, because often that's where the evidence is coming from. Of course, as it's been highlighted already, some interventions are easier to evaluate than others. I would also add that some areas are sexier than others. And there are some aspects of the evaluation where actually it's quite difficult to get engagement and interest from others, while others, people find it a bit more easier to do, a bit more easy to get funding, and so on. So I think there's an issue there. But to a degree, the same infrastructure and expertise for randomization can be used in policy interventions as compared to sort of diagnostic or therapeutic evaluations. I think there's been a perception that the need for a rapid evaluation, a rapid response, is in conflict with research transparency, openness, and reproducibility. I think we've demonstrated during the pandemic that that's not the case, but I am grateful for the challenge and pressure that colleagues, including some of you, including you, Sheila, have made to ensure that that improves. And the same applies for patient and public involvement, I think, which is an area where sometimes in health protection, that's been neglected because of the need for a rapid action. I think that synthesis of evidence has already been mentioned, so I won't dwell on that, but I will touch a bit on heterogeneity with an example in a second. I think at the end of the day, one of the risks is not making the effort to evaluate. It is an effort when you are when you are so busy, when you're in the middle of the response, when there's so many demands of your time. And a bit like has been mentioned already, I think we should, if an evaluation has not been undertaken, consider whether there are approaches to actually do some retrospective work, because these situations come up again. And it wouldn't be, in my experience, the first time when we face the same questions that were not answered previously. And of course, there have been issues around capacity and capability, and that's a risk. One of the, we talked a little bit earlier as well, I think Matt Hancock mentioned this, some of the issues around data access and barriers to data sharing. I think this is one of the areas that has improved, thank God, during the pandemic. So which COVID policies needed evaluation? So I think that from a public health perspective, actually most of them, it could be argued that needed evaluation, and therefore prioritization is key. the lack of evidence on non-pharmaceutical interventions, I think, is extensive, but also the importance of evaluating testing and tracing approaches and policy. Enormous amounts of money, as Teresa highlighted, have been spent on this. And actually, at the moment, we are none the wiser as to what's the best approach for large-scale contact tracing. In fact, we are doing some evaluations on this retrospectively using routine data, but it was really challenging to do that in the midst of the pandemic. And of course, this was a highly sensitive issue, as you can imagine, and and to a degree, I would say, politically charged. It was very interesting. From my experience, one of the things that I experienced was significant hyperactivity. So lots and lots of policies being proposed and developed on a day-to-day basis. And that was really challenging in terms of prioritizing areas for evaluation. So thinking about some examples, so I wanted to share with you an example of an evaluation that actually managed to inform policy on time, because one of the issues that we found was that a lot of the time when we undertook a policy, the world moved so quickly that by the time we had the results, however rapid the evaluation was, the world had moved on one way or another. But you might recall that earlier on in the pandemic, there was a proposal and interest on the potential for screening population, particularly maybe healthcare workers or others, with rapid antibody tests. And we did an evaluation that highlighted that the positive predictive value in the sort of context of the prevalence that could be expected at the time would actually be of concern and lead to significant errors in reporting of cases. And I'm pleased to say that this led to informing policy. And as you know, we did not spend lots of money on screening of rapid with rapid antibody tests.
Can you round off?
Yeah. Very quickly, we evaluated the impact of local contact tracing partnerships. As you know, we work with statistical colleagues to find a mechanism to use time series to help us understand best approaches for contact tracing. And as you mentioned in the introduction, we undertook an evaluation of daily testing of contacts of confirmed COVID-19 cases as an alternative to self-isolation. Unfortunately, by the time, there were lots of challenges with this, but by the time the results were ready, the policy around testing and isolation had moved. And in fact, the policy changed during the trial, although it was done within a small number of months. So lots of learning. You've got some of my sort of key points there in terms of how we can work with you and how you can help. We're keen to work with you in peacetime as well as in emergencies. Your help with development of methods for rapid evaluation would be most helpful, and continue to provide that challenge and advice.
Thank you, Isabel. That's a very rapid tour through an extensive piece of work. Now, our final speaker is Chris Robertson in this session. Hello, Chris.
Hi there.
I'm sorry we're late in coming to you.
Not at all.
And look forward to your presentation.
Okay, I can start now.
Please
my
do.
slide I can see there. Okay, I'm going to talk about the collaboration that I was involved in Scotland, the Early Vaccine Effectiveness Study, or EVE2 as we call it. Now, and it's a collaboration with lots of people there. I'm speaking primarily or totally here on my own benefit. And although I've been on government committees, this is my own views here. So I'm going to run through a few aspects about the setting up the study and what challenges we faced and what I think were the key aspects of it. there. One of the key things was the way the team that were involved in it. And what I want to just to focus on with this is that we've got a whole group of academics working in Scotland with a whole stack of other people, public, patient, individuals here, project managers, but a whole stack of people who worked within Public Health Scotland. And the key thing is that all of the analysis was done within Public Health Scotland using honorary contracts or by analysts who currently worked in Public Health Scotland. So the background for this is actually we started about 12 years ago with this collaboration looking to look at early assessment of vaccine effectiveness in the H1N1 pandemic, and recruited individuals from 40 practices and looked at the data within PHS. And then we carried this on with other work on seasonal vaccine effectiveness. The thing about that one is that our first work took 2 years to complete. So it was published in 2012, a couple of years after the pandemic. And even this study on vaccine, seasonal flu, we upped the sample size to 230 GP practices, but did the work in the safe haven. And both of these, of working within the safe haven and working within Public Health Scotland, led us to take a decision late on when we got funding for this EVE2 study from the MRC. But that was again only for a quarter of the population of Scotland. But we were asked by the Cabinet Secretary to scale up to the whole population, which we were able to do because we were working with a company, Albasoft, who were able to extract in real-time data from GP databases and feed it into Public Health Scotland there. And the kind of aims we had were that we didn't know when we set up the study that we would be able to evaluate the effectiveness and safety of vaccines. So we had another aim of the epidemiology of COVID-19 and what different patterns of healthcare, which we knew we could complete. But in the event there was a vaccine, and we looked at safety and there. Now the data structure, and this is quite important for the success of the project, was that because we had permissions, ethical and privacy permissions to access these data from everyone in Scotland, that what this did was gave us a population spine of everybody who's living in Scotland at the beginning of the pandemic. And through accessing all of these routinely collected healthcare data sets, we could track their follow them up through the couple of years that we've had of the pandemic. And we were using the most common data was the vaccine database, hospital admissions, consultations, prescribing data, testing data there as well. So these were all linked together within Public Health Scotland at various times for this analysis. Now, we've had quite a lot of major outputs, and I'll just focus on a couple of them. So we did real-world vaccine effectiveness of one dose of the vaccines in Scotland, probably about February. The results started coming out, and this was quite a stressful time doing all this work, but it showed the vaccines were effective there, although it was done at a time when there was a lot of infection around. The key thing about this piece of work is that we were able to do the same analysis multiple ways within the same data set. And that was also true when we looked at the safety studies on thromboembolic events in Scotland, that we did not just a self-controlled case series, which most people do for this, but we were also able to do case control studies and observed expected using this mechanism within our cohort. And again, we followed this up with work with colleagues in Brazil, looking at exactly the same analysis using the same vaccines in two separate countries where different variants were circulating to demonstrate waning of the vaccines there. And this one about vaccine failures is actually one that we've now extended to working with Public Health Wales, Northern Ireland and RGCP in England to do the same analysis in 4 centres in the UK by sharing code and analysis scripts to update this work. Now that takes a lot of time to do that, this collaborative work over the whole UK. So what I think are the key aspects to the success of this project was at the very beginning, when we set it up in April, May, June 2020, we had a lot of consultation with general practitioner representatives from the two main bodies in Scotland, using the GPs and consultant within PHS. And the GPs were happy for their data to be used in this instance, provided it was only used for coronavirus pandemic work. And the main concerns were about patient privacy. And what that means is that we couldn't get the full record for a patient, but we could only get groups of codes together. So for example, we knew that they've had asthma, but not all the different types of asthma that they could have. And we also had to use an anonymous identifier, which was not the identifier used for all of the linkage work within Public Health Scotland, which is the Community Health Index. So we had this extra layer of privacy so that all of our analyses were done using this link number to link individuals together. And that meant we couldn't go backwards, have it with identifying patients. The second key aspect for the speed and the utility of this was doing the whole project within Public Health Scotland, within the safe haven there, rather than within the IDRIS safe haven. And that sped up the whole analysis greatly, but it meant that there were some difficulties for Public Health Scotland setting up two confidential areas, one where the named data was resident and PHS analysts looked at it, and the other area where there wasn't any named data, but all of the analysts working on our project could do it. And because we were working within Public Health Scotland, that meant we had real-time data on a daily basis during the pandemic, and it also gave us speedy approvals through the Privacy and Public Benefit Committee. Other aspects that the PIs on the group were all involved in some aspects of the national committees. And what that meant was that questions that appeared there, we could look at them very quickly, and we could also feed results in there as required. And for the long-term kind of strategy and technology transfer, that actually works both ways, because what we've had are these academic researchers working within Public Health Scotland, and that means that they're effectively training the analysts in more up-to-date statistical techniques, but at the same time, the analysts in the universities are beginning to understand or get to understand the data structures much better. And once, to be an effective statistician, you need to understand what all the variables mean and how it contributes to that success. So the lessons that we learned is that it was actually a big step change from the first project up to the last one. And it had quite a lot of benefits working within the Public Health Scotland. We still have a lot of areas for improvement. About some new data sets take a bit of information governance to get approvals for. It would be really useful to have more granular GP data and to extend it past coronavirus to look at other areas there. And the encryption of CHI meant that we couldn't identify individuals. And sometimes that was, when you were looking at safety concerns, that was sometimes a problem. And one of the key statistical benefits I find from this whole analysis is that we can carry out multiple studies of the same question using the same data set. And that's one of the issues with all these observational studies, is adjusting for bias and controlling confounding. And we have routinely analysed the same outcome using different study designs within this cohort. And routinely we're using test negative design, target trial and cohort studies as appropriate, really to try and get out the differences between what these different methods report when they're talking about vaccine effectiveness. because the vaccine effectiveness from a test negative design is something different from the vaccine effectiveness from a cohort study, because although you're comparing to unvaccinated, there are different types of unvaccinated people. So that's all I want to say. Thank you very much.
Well, thank you, Chris. And I'd like to thank all our panel and now open us up to questions. I hope Chris and Olivia are still with us. So the question that I would like to start us off, because it relates to vaccination, back in December 2020, a decision was made in the United Kingdom that both the Oxford vaccine, but also the messenger RNA vaccine should be given with an interval between the first and second dose of 12 weeks, not 3 weeks as originally licensed for the messenger RNA vaccine. And so I'd like to ask the panel whether they think that public health decision should have been subject to some form of randomization. Chris?
That was looking away, hoping you wouldn't ask me first. Should have put my camera off. Well, ideally, one would try and randomize these things. I think in the time scale, it's phenomenally difficult to try and make sure and convince everyone that it's a fair randomization process there. I think post hoc, we can do some analyses to see whether or not there was any disbenefit to having a shorter interval or a longer interval there. But I think from the speed, it's just phenomenally difficult to randomize. It's the same thing about whether you got the mRNA vaccine or you got the AstraZeneca vaccine. And that largely, from my experience, it depended where you were. I mean, in Scotland, if you lived in a care home and were over 80, you got the Pfizer vaccine. If you lived in your own house, you got the AstraZeneca vaccine there. And if you were under 70, between 40 and 70, it was roughly, tossing a coin as to whether you got what was being offered at the time you turned up, what vaccine you got. They're not true randomization processes, but it might be possible to look at that aspect there.
Thanks, Chris. Max?
I tend to agree with Chris. I think ideally you would want to get some sort of randomized evidence against a shorter interval versus a longer interval, in this case 3 versus 12 weeks. The challenge, I suspect there wasn't the political will to answer that question. And they're ready to roll it out, and to then get an answer which didn't agree with your rollout would have been a real challenge, I think, to manage. And also doing a rollout while you're trying to get an answer to the question, to explain uncertainty about that duration at the time would have been very difficult as well. So I suspect the political will just wasn't there to do it.
James?
Yeah,
Doctor.
I think obviously you want randomized evidence. Everybody knows that. The question is, what is the challenge? And actually, what's more interesting is the fact that we rolled it out by age, very sensible, and the population liked a lot that it went out in a completely equitable way, decade by decade, and worked well for uptake. We missed an opportunity to, if we managed to roll it out in a different method around the country, so you could have got some information, but from vaccine efficacy as the variants changed, it would have been really helpful. But as it happens, it's virtually impossible because everything was, the major confounder age was not, there was no variation in use across age. Therefore, it's been very difficult to work out different vaccine efficacy against variants over time because it was done, the major confounder was not randomized or chaotically done. So the real block is the idea that it's all right to give out chaotic policy, but you mustn't randomize. So, in other words, if you're not going to get any information from your chaos, it's ethical. But as soon as you get information back from what you've done, you should have got consent. And that, I think, needs careful thought, that when you've got 1 week to decide how to do it, and expect to get any consent or ethics in 1 week is impossible. And therefore, is there a way of doing it in a way which allows you to infer something without ethics and without being sort of torn apart by the ethics police? I mean, you can't publish because you haven't got the ethical thing. The whole thing, I think, needs serious thought about how you can get some sort of preparedness for this. The point about the 21 days, by the way, is that a lot of thought was done to that, and they thought that the Pfizer people were wrong to go for 21 days. The evidence was longer, and they felt was they went for 21 days for commercial gain, and they were pushing their luck to go make it. They wanted to make it as short as possible, and the sensible thought was 12 weeks was clearly the optimum choice, and Pfizer went for 3 weeks for commercial reasons. So that was the reason why they did that.
Teresa.
Knowing nothing about the content, and I'm interested that Max was attributing the absence of randomization to political will. I just wonder what the scientific uncertainty was, and I don't know what the priors were going for 3 versus 12 weeks, and depending on if one saw that scientific uncertainty, and if the scientists were pushing for it, then I think something might have been possible. I don't know also whether it was possible for any so-called natural experiments, which always seems a bit of an oxymoron, but if there were sort of matched jurisdictions that were going for 3 weeks as opposed to 12 weeks, it's less than ideal. But I don't think we should assume political will in the context of drugs is a major barrier necessarily.
Well, there was a disunited kingdom phenomenon, yes, whereby in the January, 30% just about, I think it was, of those who'd had their first messenger RNA vaccine in England got their second one at 3 weeks, and whereas in Scotland, it was only 5% got it on schedule, on the original schedule, and in Northern Ireland it was about 50%. So doctors took different views in the different countries as to whether, in fact, they were going to keep the instruction for those people who'd already received their first dose. But after that, there was compliance, and the issue was because it was the world's first messenger RNA vaccine, and what we knew about a vector virus vaccine, longer interval being better, there was no evidence that that was the case for messenger RNA. Sorry, this bit is just the panel discussion. Sorry, and my last question to the panel, if I may. I don't know if the panel's got any, is what about this thing about elicitation of priors? We didn't hear a lot about how that happened. I mean, the one that I think about, it wasn't a randomized experiment, of course, it was the moonshot, where in policy people seem to think that 3/4 of the public would turn up to be screened using the lateral flow test in 2 or 3 weeks in Liverpool. And in fact, it was a quarter. And I think no experienced biostatistician would have dreamt of it being anywhere near 75%. And so I wonder who does the elicitation of priors, or who comes up with these priors that because some of them were way off beam.
But there are sorry. I would suggest that there are priors that might exist in policy circles, but SAGE papers are littered with expectations, priors, which are based on estimates of people's behaviour in not dissimilar contexts. So littered with those priors. Which, not always, but in this context, were widely different from those expectations. But as I said, there are different methods, and there may be some political motivation to go with some methods, whereas I'd like to think that those who were generating the papers in SAGE were using a mix of methods.
Yes.
And estimating a range.
Right, I'm going to catch us up and stop our panel discussion and go on to our contributed speakers now, if I may. And in fact, Ed, you are the first of those. So this is Ed Humphreys from the UK Statistical Regulation. And our 2-minute contributors are speaking without PowerPoints, just for slickness.
Okay.
Yes, please do.
Good afternoon, I'm Ed Humperson. I'm the head of the Office for Statistics Regulation. In my 2 minutes, I'm going to do 4 things. My role, explain my role. I'm going to explain my terms. I'm going to give a verdict, and I'm going to say what that verdict means for the RSS inquiry. So our role at the Office for Statistics Regulation is to ensure that official statistics serve the public good. And a key aspect of statistics serving the public good is that they enable evaluation of policy. In terms of explaining my concepts, I'd like to distinguish between 2 notions of evaluation. The first is a broad, a loose, almost a popular sense of evaluation, and the second is a tight, rigorous, closely defined version. The broad version is evaluation or statistics enable people, all kinds of users, to form judgments, to get a sense of what's going on, to form a picture. And the tight, rigorous sense is what we've been talking about thus far, quantified causal conclusions based on very rigorously defined methods. So those are my terms. My verdict is the broad sense, this broad, enabling people to get a sense of what's going on. I think statistics performed pretty well. There was lots of data. Those data were often available in granular ways, and we know they were used heavily. However, in the tight, rigorous evaluation as a search for quantified inference and causality, mixed at best would be my verdict. There are, of course, some good examples of RCT designs and so on. We've heard about them this afternoon. But in general, there was a generic disease, which you see in government, of being too program focused on programs as mechanisms for delivering government ministerial priorities and gathering as much data as you can. I think this was true of test and trace. We've already heard about that. It's true of lateral flow tests. I think it was also true with some of the vaccine rollout. In a way, I think the message here for the RSS is that there is a downside for a heavily datafied approach to policy. If we think of data and policy, an obsession with data can lead to just gathering numbers for their own sake. So my advice for the inquiry is, under my broad definition, celebrate the ability of statistics to enable lots of members of the public to engage with aspects of the pandemic. On my tighter definition of evaluation, challenge the government to build in evaluation at the outset of programs. And that's certainly what we will continue to do at the Office for Statistics Regulation. Thank you.
Thank you, Ed. And Tom Whipple, please, who is science editor at The Times.
Hello. So if I feel moderately intimidated, I'm not an expert on stats. I'm not an expert on trial design. I'm a journalist, which means the thing that I do have expertise on, that I'm going to talk about, is messy social media disputes. I'm going to talk about masks. As a journalist, I feel like I've been involved in a lot of these debates, if only as a sort of receptacle, maybe as collateral damage in a lot of these debates. And I've seen what's happened with and without evidence. About a year ago, I just think recall being invited on the radio and asked to talk about masks, and the radio presenter said, "So, give us the evidence for masks," in a sort of, slap down those anti-vaxxers kind of way. And I sort of had to pause and say, well, you know what, it's not great. And I feel very nervous saying that here because I know what Twitter can do with these things, because masks have become political. They're unpleasant, they're a tribal marking, they're Brexit Remain, they're not public health intervention anymore. They're a sort of a facial shibboleth of your politics. And I think that's a lot of that has to do with what's happened to the evidence. And I know what would happen if my sort of these Twitter people in my head hear me saying this. They will come with a massive portfolio of evidence. In my experience, there will be case control studies, there will be modelling studies, all these things. In my experience, massive portfolios are often, that's what happens with ivermectin. People have a massive portfolio of evidence showing that ivermectin works. Nobody has a massive portfolio of evidence showing that dexamethasone works because you don't need it. You should just point to the one trial. And equally, nobody has a political style. I cannot infer your politics on the basis of your views on steroids late in the course of COVID. And I think this is. I'm not saying that masks are ivermectin to inoculate themselves against Twitter. I think, I'm pretty convinced they work okay in some circumstances, but I'm not convinced we provided the base until too late or even then. And I think probably people died because of it. So to my knowledge, there are two decent trials. There's the Danmarks study, which looked at the effect on the wearer, but it wasn't powered to find effects beyond about 50%, which would be a huge finding. And there's the Bangladesh RCT, which was a cluster randomized trial where they encouraged masks in some villages and didn't encourage them in others. And in that trial, they found that surgical masks work pretty well, and cloth masks sort of work. But this is the one trial that I can point to in one very demographically different place, very socially different, completely different climate. And one thing, and this is why I think that lives might have been lost, because by the time this came out, it was so political it didn't matter. This was the thing you put on your face to say what you do. And the key bit of information in this is, surgical masks, which don't cost that much extra, really definitely did have an effect. Whereas the cloth masks, which actually aren't that much cheaper, it was a lot more marginal. And I just think, given the amount we spent on lateral flows and all these other things, actually a little bit more money on, it's a what if. And I think if we had a lot more evidence early on, it would have been a wonderful thing.
Thank you. And Professor Julian Peter, Professor of Epidemiology at London School of Hygiene, Tropical Medicine.
Well, my obsession from the beginning of this epidemic has been that if you want to test and trace, the first thing to do is to test, and you've got to test the whole population regularly, or the compliant population regularly, to have any chance of picking up a substantial proportion of cases that you wouldn't pick up anyway symptomatically, and also being in touch with them so that you can give them advice. And to test the whole population once a week, which is the sort of frequency you need to be effective with a disease like this, would require 10 million tests a day. And NHS Test and Trace with the £37 billion and vast numbers of Deloitte consultants, it got up to 800,000, I think, at the peak after about 18 months, which is less than a tenth of what was required to have a serious impact. And the one thing which was promised from the very beginning of the epidemic, it was announced, in fact, publicly in April of 2020, that the entire population of Southampton was going to be tested once a week to see what happened. And it never took place. That trial was never done. And that's the one evaluation which I think really was important. Now, the point about testing the whole population is it's done by an NHS lab, it goes straight onto your NHS record. So you actually have real-time information about who's getting infected, what the infection rate is in households, whether households locked down, the effect on the spread of the epidemic, and potentially a very large impact. And finally, what was done eventually was simply spraying the population with lateral flow tests, which were self-read and very often not reported, and certainly less sensitive than better methods. And I think the great tragedy of this epidemic, and this could make a huge difference in the next pandemic. I mean, if you had facilities in place where you could immediately test the whole population once a week, I mean, I think it would make a profound, I think it would have prevented the pandemic. I think it would have controlled it without the necessity for lockdown. As I say, this was accepted very widely and never implemented. Now, an important detail in relation to this is the means of doing it, and the two ways which are practical. First of all, the lab has to be local. You don't set up huge labs which take a week to get samples there and results back, and half the time don't manage to do that. If you've got a local lab, and by local I mean serving every population of about 200,000, and there's 30,000 tests a day to test 200,000 people once a week. And that's easily achievable. And it can be done in two ways. It can be done by recruiting all the people who've got PCR machines and organising them to do it. And that I think that's perfectly feasible. And I wrote a letter to the BMJ the day before the first lockdown in March 2020, recommending it. But the far better way, in my opinion, is the thing called RT-LAMP. I mean, loop amplification is as good as PCR. It works on saliva samples. And that was a perfectly feasible alternative, which was never developed. So, I mean, those would be my two evaluative recommendations. Invite the whole population of the town once a week. You know, put the invitations and the results on the NHS records and try to get with RT-LAMP.
Thank you. Aaron Child, who is an occupational health physician.
Yes, I've treated, because one job is not enough, I have three. I'm also credentialed in economics, specialty or area that hasn't actively contributed, in my opinion, to the control of COVID. The area of policy design and implementation is very much taught in economics classes. You know, there are enough, I'm sure, professors in London itself who would vouch for that. My particular area of concern with regard to the control of the pandemic was in relation to what I perceive to be a very knee-jerk reaction. The emphasis was more on passive measures that people were told to do, as opposed to how they could themselves participate. It's all very well to be, you know, rattling pans and saying, you know, we appreciate the work of the NHS, but what I feel has not been emphasized enough is the fact that people should have been given charge of their own health and of their own ultimate destinies, because we know that obesity and smoking, for example, have huge implications for all respiratory conditions. And even when news of the pandemic broke, we knew that getting people to slim down and to give up smoking, it would have been an ideal time to drive that message home, because from behavioral economics, I realized there's a behavioral expert on the panel. There is a nudge factor, that if you tell people that if you strike when the iron is hot, you will have a response. So that we have lost out. We have focused on the present to the point that the long-term benefits of improving the health of the public has not been addressed appropriately. And the problem with a lot of health promotion advice is that there's it is viewed very badly. You know, you ask people to give up smoking, they'll take offense at it. If you ask people to reduce their BMI, again, it's very not very well received. So we have this element of conflict of self-interest. You know, because you don't want to be considered as a bad person for telling people what to do, people tend not to give it enough importance. And because we live in a welfare state, in fact, a lot of nations are welfare states nowadays, especially in the West, you have this moral hazard that you pass on the detriment of your health behaviors to the general public at large. So I believe that a confluence of several areas of expertise, you know, and behavioral science, economics, and statistics and public health would help in addressing future crises.
Thank you. Nigel Jackson, who's the founder and managing director of Think Media Consultancy from the business field.
Hello, my name is Nigel Jacklin. I own and run a market research and data business. I'm what Matt Hancock referred to as a translator. My contribution concerns lockdowns and low threshold case definitions. I'm not convinced by the official narrative that COVID was a very deadly disease whose impact was mitigated through exceptional and heroic measures. My alternative hypothesis is that COVID was a fairly bad disease and the measures taken did more harm than good. The decision to impose lockdowns in March 2020 was unprecedented, running contrary to conventional medical wisdom. It followed their purportedly successful use in China. The subsequent use of a low threshold case definition boosted the number of reported COVID cases, making the disease real in the public mind. In theory, it may have helped stop the spread, but there may also have been a degree of futility in attempts to do so. And as more people tested positive for COVID with no symptoms, this busts the myth that it was both highly prevalent and very deadly. It was clearly not both. And by this time, the suffering and adverse impacts of the measures were becoming clear. So, to conclude, in business, some people actually did very well out of COVID, and some people did not. We need a diversity of views in situations like this, and that's been difficult. My question is, to what extent were the decisions such as lockdowns and the case definition based on political judgment or how things might look, supported by narrow field experts with a predetermined view, and what does the evidence look like for their use in retrospect? Thank you.
And finally, Tracy Brown, who's the director of Sense About Science.
Thank you, Sheila. What a fascinating session. So I suppose my relevant bit here is that we developed the Transparency of Evidence framework, which is now in the Treasury Green Book as a thing. Transparency of evidence is a thing. And confronted with the first time that there has ever been mass engagement with the policy interface, we have just completed an inquiry, what counts. We looked at it at scale. For the first time, we were able to survey the population as to their experience of trying to get hold of policy evidence. We did a NatSense survey last year. We then interviewed everybody from rural bus drivers to fostering agencies and others about their experience of trying to implement and policy and get evidence. And the point I suppose I want to say is, it's all very well to dig down into trials, and I'm so fascinated by the learning that there is. I'm really appeals to me to see there are genuine insights from this that are new, but there are also frustratingly lots of old things that we know need to be thought about. But, unless we have honesty about what the policy's goals are, we can't really ask good questions about what we're seeking to optimise. And that's been one of the biggest problems all the way through. Modellers were not asked, where's the sweet spot between closing schools and preventing transmission? If they had been asked that question, they would have probably come up with a fairly good answer, especially since Warwick were involved in the modelling, who actually specialise in those kind of questions. So that's the thing. There was a great dishonesty with the public and a real sort of squeamishness about talking about the fact that there were trade-offs to be made. And what we were looking for was how to be the most effective at the least cost to society. That was pretty quickly came about. Sometimes I think it was just a failure to kind of realise that you needed to set these things out, both for researchers and for the wider public. And I think in looking at this, the question set, in this session is also, how do we prioritise what to evaluate? There needs to be consideration of the dilemmas that confront people. It is not experts, media, policymakers, and everyone else out there. What there are out there is thousands upon thousands of people having to make complex risk assessments. For example, in here we have people like bus drivers saying things like, how do I calculate whether to leave a kid at a rural bus stop with no pavement against the risk of letting them on the bus because they haven't got a mask? Right, I've got two types of risk. Do we let this foster placement break down? That's a threshold threshold, that's a non-linear risk. It breaks, it's ended, the child's devastated, right? Versus, the fact they won't put their swab up their nose because they're being hysterical about it. It's those kind of trade-offs that thousands of people across society were forced to make, and many of them felt ill-equipped. So whenever we look at what we're going to do next, we also have to think about what are the mechanisms, both political and sort of, I suppose, technical, research-based, that solicit those questions and draw in those dilemmas very quickly when you're asking masses of people to overturn the services and facilities that they provide and provide them differently, and to make those kind of trade-offs. We need their input back really quickly to decide how to set the question in a sensible fashion and one that answers it. That's how we prioritise, I believe.
Thank you very much. Now, we have an open discussion with our in-person audience. Oh, I beg your pardon. I do beg your pardon. I forgot. But the virtual one, my chairing is falling here. Right, sorry, Susan. I'd forgotten about the virtual talks.
It's okay, Sheila, almost more interesting to hear what you're all going to say in the room. So it's a pleasure to be here and to just comment briefly. I have enjoyed listening to the 2-minute presentations and to the longer presentations before. And I think the interface between policy, evaluation, statistics and research have become plain to see throughout the pandemic. And I think for me, in preparedness for the next event, it's thinking through very clearly about what we want to evaluate, why we want to evaluate it, and how those valuations are going to be done. As we know, and as Tim very eloquently put it when he was presenting, trying to do studies at rapid pace with rapid results that can inform policy are extremely challenging. And the only way we can do this effectively is if we have thought through the possibilities before, have things ready, and have government and the people engaged with those decision makings on what are those studies that we could do and should do in an emergency situation. So again, I think that the ideas that people came through on in many of the areas just were not able to be evaluated at pace because of policy decisions that were being made. Some of those were evaluated retrospectively, but they're never going to be as effective and as robust as prospective, thought through, open science papers, open science protocols. And for me, in the learnings from this pandemic are thinking through the possible interventions, the possible evaluations that we can do, and having those ready and waiting for the future state.
Thank you, Susan. We pass to Ian Russell, please.
On the 14th of April 2021, I organised a symposium on the public's health after COVID for the Royal College of Physicians of Edinburgh. That included 8 generally evaluative papers, 7 quantitative and 1 qualitative. I edited those papers for publication in the supplement to the June 2021 issue of the College Journal. Thus, both symposium and supplement were mainly statistical. Though the editorial team judged all papers as high in quality, most compliments we received mentioned the sole qualitative paper. This carefully reported 6 case studies, 4 about homeless people receiving special help during COVID, and 2 about successful service changes in response to COVID. This preference for individual stories reflects the reported views of the media and the public. Trialists face similar dilemmas. Qualitative analysis of subgroups often gets more attention than full statistical analysis of the trial population. Trials units have responded by developing standard operating procedures to enhance trials by adding qualitative flesh to statistical skeletons. Statisticians who accept the public's preference for stories over robust analysis need to work with rigorous qualitative researchers to integrate their evidence with ours. Thank you.
Thank you, Ian. Now we pass to Ian Buchan from Liverpool University. Ian.
Thank you. My camera and mic have just been enabled. Thank you for inviting me, Sheila. So I'm a professor of public health and clinical informatics at the University of Liverpool and led the evaluation of community testing pilot in Liverpool. I've also been an RSS fellow for the past 30 years, and the perspective I'll give is one of wearing two hats for measuring uncertainty. One responsibility as a public health physician to my local population for situational awareness and tactical intelligence on a regular basis as this pilot was implemented. The other is in developing policy evidence that's externally relevant. As Sheila mentioned, there was a complex intervention. None of us from the public health community expected for half of the population to come forward for testing every week. But we thought that this would be a complex intervention surrounding communication and not have a one-to-one relationship between test and transmission chain. 57% of the population from November 2020 to April 21 came forward for testing. In the initial push with military assistance in the first 5 weeks, there was an overall effect, we estimate, of around 43% reduction in hospitalization. Case detection rose by around a fifth and cases decreased by around a fifth. There was then a systematic rollout to the surrounding population where synthetic control analysis, we estimate around a third reduction in hospitalization. That was only achievable with all England data available 9 months later. For the work we did that provided tactical intelligence on the ground, we were able to show very quickly that during the pilot, we were able to make very quick analyses and tactical decisions. For example, analyzing small areas showing that internet user classification of those small areas was a more potent predictor of low uptake than material deprivation. It was important as it highlighted the difficulty of access digitally to testing and affected the rollout of our testing in Liverpool. For the national results, we were able to produce the following summer required access to all England data, hospital episode statistics linked to test results. And an important lesson from this evaluation, which did have powerful results from synthetic control analysis, was that those policy relevant pieces of evidence could have been produced very early in 2021 if the All England data were available at the same granularity and timing as the combined intelligence that was available in Liverpool.
Thank you, Ian. Can we go on to our final speaker, Camilla?
Okay, so I think the main point I want to address is the preparedness for the next pandemic or the next crisis. I know we're still in a pandemic, but there's lots of things that we should learn and try to prevent, and some of them are part of how the RSS and statisticians in the country should respond, at least from my point of view. One of the things that it was quite problematic from the beginning is that the relationship of statisticians with the local authorities, public health teams was close to non-existent, especially university-based statisticians. I quite envy Scotland as is. They had potentially the best team in the partnership build-up. From at least Durham's perspective, we built the partnership over the last 5 years or so. So being able to be part in being embedded as part of the council was incredibly useful. But I did see other local authorities in the region that did not have the same sort of support, and the RSS was driving a national response while potentially neglecting the local response. As part of the Durham University service evaluation on the deployment of LFTs, we had a very tight community, and when you talk about low participation rates, it was the build-up to the how to engage the community that was incredibly important. And because we already had engagement with our local authority and public health team, being able to deploy that service evaluation was relatively easy. So I would just really ask the RSS to rethink how statisticians engage with the local community, and potentially put the burden on universities to push the community to actually engage a little bit more than they did, or it was a bit too late in some cases. Thank you.
Thank you, Camilla. We missed some of what you said, but the online audience was able to. Okay. So what I'm going to do now is just have a very brief session of questions from our audience here and anything that we've picked up from the chat. So yes, and so our online audience, if you have questions that you would like to put, we will stop at 5:15, and so we've just got 20 minutes.
One question, I remember towards the end of the first lockdown, obviously schools were a really controversial thing, and I had this kind of fantasy that we did one of those, if you call them step wedge things or something, where you randomised half of them opening a week earlier. Do you think if we'd done something like that, would have actually got useful and usable data?
Yes. Right. I think, we did something. In fact, in the autumn of 2020, we had a pilot study of 4 or 5 schools where we were testing daily contact testing. It was how it worked in a few schools. And you could, a step wedge design would have worked. The challenge was getting parental and school and governing body buy-in for that sort of imposition. And I think one shouldn't underestimate the sort of anxiety both ways.
From the...
Yeah, perhaps the key there is to have that communication in situations where we don't have a pandemic and discuss these sorts of issues, so people are ready to address them at speed at the time, rather than trying to do them in extremist situations.
Your evaluation ready.
Yes, exactly. That's part of it, isn't it?
Yes.
It also sounds as if the school experiment might have helped kids to learn about science and hypothetical things, but that might have been unacceptable to people who felt that they were hypothetically being excluded from a progressive.
But coming back to the question at the back about apples and pears and different risks, what we were discussing in our school study is how many cases of COVID equals the number of days lost from school. And that equation, which is what you're actually trading off, how you decide what the cutoff is really challenging. And quite difficult to get a proper discussion on, because they got really heated about it, I can tell you.
But I think what one of the 2-minute contributors was saying is that people were also making their own kind of balanced equations.
Yes.
And those were quite difficult. And I suppose what happened is that policy has to be simple. We're all told we've got to do something. And then that means that you can't evaluate the hypothetical alternative to the policy because we've all got to be told to do something. That's not really a question.
There are no questions online. Tracy.
A couple of things. One just quickly to say, I think the policy doesn't necessarily have to be simple. or neither does communication have to be simple. You just have to think about how do you equip people well, how do you empower them with the decisions that they've got to make. I think there was an explicit conversation at the very beginning about giving people simple messages because they could police each other better. That's a debate for Teresa and her colleagues. There was an authoritative versus authoritarian row, and an authoritarian won out through the number 10 communications machine because they just won Brexit and they've won a few other things too. So that's what dominated, unfortunately. But I don't think it's necessarily simple, just clear. The other thing I wanted to raise here is the ethics issue, which is to do with what Max was saying about sort out some, so like make hay while the sun shines stuff, because all those accusations, on the one hand, you had people raising quite serious ethical issues around consent and things like this that needed to be raised because you had that sort of, yeah, well, who cares about that? You know, we've got a pandemic to deal with. On the other, you had the whole sort of throwing of ethics around where it's really unethical to run a trial on young people in a warehouse having a rave. I mean, never mind the study design. But it's perfectly ethical for them to pack my asparagus for the Waitrose delivery in the same warehouse just up the road. So you had that sort of use of ethics, which was rather worrying, really, on both counts.
Yes, I agree with that completely. And we need to have some of those discussions in, as you indicate, in the cold light of day rather than in these sort of high temperature situations.
And it was interesting that in Scotland, they didn't use just the community health index, but introduced another pseudonymizer. And that was for the protection of GPs in sharing the data that had the associated community health index. And so that's in the system where over the past 25 years, the public has been taken along in the arguments about sharing of data. And yet there was, nonetheless, because there was a lot of additional linkage going on, there was an extra level of security put in. That contrasts rather with the approach that Matt Hancock was voicing, that now we've had an example of Hooray Henry during during COVID, that we can do all of this linkage, then we want to hold on to that. But I think there is a public debate to be had as to what the public is content for during a pandemic, where there may be greater permission than outside of the pandemic. Yes.
Teresa was mentioning about, the natural experiment, and it's not well regarded, I agree, among statisticians or clinical trialists. But there are some situations where you do not have data and you do not have the opportunity for designing a trial with all due ethical committee approval and the institutional review board and so on. So sometimes you have to work with what you have, and that's very common in economics, for example. When you have a policy change across borders, in economics, they have a lot of these natural experiments where you can draw adequate conclusions, and you're looking for pointers. You're not looking to please some god of ideal clinical trials. So you can get enough pointers for policy design and policy evaluation based on what you have. And oftentimes it may be the case that you are serving the public interest overrides your duty or your loyalty towards your specialty.
Could I just respond to Aaron? I absolutely agree. So I spoke very glibly about natural experiments, and I certainly don't hold out an RCT, in a tyrannous way to say either it's an RCT or not. Absolutely not. It's about, as I said in the 4 principles that we developed for the science framework, for the events research programme, it is about designs that maximise the possibility of inferring causality, and sometimes that is what one has. But I just wanted to shift across to some of Matt Hancock was talking about. It was the press who are unable to speak a language of uncertainty. I'd like to shift that to politicians, and I'm not the first person to have said this, that actually it's quite difficult to have political discourse that entertains uncertainty. And I think we were talking about trying to get schools, or those working in schools, possibly up to the pitch of many of those working in the NHS, to embrace uncertainty and to think much more empirically, and even presenting what they're doing as this, the evidence suggests this is, you know, probably the best way of going about. We're going to collect evidence and see whether or not this way of teaching you lot, this way, or this particular policy is actually fit for purpose. So we have that with the Climate Change Committee, which through an act of Parliament is required to report to Parliament every year on progress against targets. In the regulation, there isn't an obligation to change course in order to meet that, but nonetheless, I think that that's a beginning. So I think all of this can begin to shift the dominant narrative about uncertainty and trying to narrow those gaps between what we're trying to do with policies and actually achieving.
There was some comments in the chat.
Can we just let Chris Robertson come in? Chris, did you have a point?
It was actually in association with the confidentiality and the privacy. And actually in Scotland, we're finding a little bit of pushback now about the release of the data. We had a great support because the pandemic was perceived to be such a big threat that we got these permissions through. Now that it's no longer such a threat, or seemed to be such a threat, there's a pushback about getting more data from GPs. That is not actually from the GPs themselves, but actually from the individuals who are in the privacy committees who are questioning the legality of it there. So that's where the issue is now. And I need to go now. So thanks very much.
Thank you, Chris. Sorry, Max.
There are a number of comments in the chat. I just wondered whether we want to pick them up or just be aware of them, really.
No, please do.
I'll pick them up from 1657 because there are a few before. John Edmonds comments that it might be useful to remind the panel that we're already in the next pandemic, monkeypox. How best should we contact trace in this challenging community? How should we vaccinate? We're repeating the lack of evaluations again, and possibly for similar reasons. Pressure of time and need to do something quickly. Other comments that have been made already, so let's just Ian Buchan mentions that it would have been useful to have some data that's centrally available across the country. There may have been make heterogeneity in the observational causal inferences useful and timely. So this about data availability again.
Yes, I have a question for Tim, and it's a very humble information-seeking question. There is no edge to this question at all. Tim, you gave us a wonderful presentation about your trial, your research. So you told us everything about it except for what you found. Indeed, you had a detailed results slide which was tantalising. For me, for evidence lover, it was a cliffhanger. So could you give us the 2-minute version?
Okay, essentially what happened was that there was a modest increase in attendance. It was slightly less big than we had thought would happen, and it may be the amount of it we probably didn't confused COVID-related absence with the rest. And I think people were obsessed about the small number when they got their child in the bubble. It makes a huge impact, but there's quite a lot of other absences, and therefore the total impact on the absences was less than we thought, but we saw it. There was, surprisingly, if anything, less transmission. I mean, symptomatic disease across the school, in the intervention school, randomised the intervention arm, not. So it actually was a safe thing to do, because possibly there's more screening going on if you were in an intervention school because there would be no bubbles. There was another intriguing result, which was not in our paper, and it didn't really be published, but I mean, it's honest, was in the years 11 and 13, at half term, there was some schools sent their children home, and end of school, they had a holiday. And some of the schools, they carried on. Well, year 12 carried on. And there was a clear-cut reduction, increase in transmission, in symptomatic cases in those children that were sent home at half term, because we think they mingled more at home areas. And we think school, I'm not saying that in a public arena, but just privately, we thought the school environment was probably safer than outside school. That was an intriguing paradox. And the number of secondary cases after DCT there was virtually no onward cases attributable to the DCT. So it was a safe thing to do in the school environment.
Fantastic. Thank you very much.
Well, ladies and gentlemen, I've chaired this appallingly, but I think we've, by contrast, had. Is there someone else?
So you're 8 more minutes.
Well, if there are no more questions, then I think.
Yes, it's about the public being informed, and I think in the evaluation paper that the RSF published, there was some media were praised, and there was a call for more information in the public. Actually got a hell of a lot. So what is it that the public need? Is it better explanations of stuff, or do we believe that the public are able to understand lots of different things? Personally, I do.
You know, listen, I thought that having the Mail Online in their daily bulletin of how many cases there were, which was well presented, and they did it every day. There was numbers of cases which would be looked at for weeks and weeks. There was even a commentary, which there it was, bland. I think it made a huge difference to the public's paranoia about what was going on. I felt that the level of discussion about the state of the epidemic was improved enormously by the bland figures just being presented. The only criticism I've got that is living on a log scale, not on a linear scale, but that's minor. But I would have thought the more straightforward, honest statistics you put out for people, well presented, improves the level of debate. What you don't want is journalists giving you the sort of semi-digested slant on the statistics without letting people see the real facts. That causes confusion, I think.
Perhaps just take that a step further, though. We've got perhaps beyond the idea of collecting and presenting data, which we've done, I think, as others have said, pretty well in this pandemic. But we haven't gone to that further step of making the argument for evaluations and the difference between collecting data and making evaluations, and then doing those evaluations and showing what how you might implement them. And that's probably where we need to move to.
Yeah, I mean, I've got sort of bruised by lateral flow test debates when I was doing evaluations for the government on lateral flow tests. And the first thing, we couldn't publish the results because it was all government controlled. Very difficult. Not that we couldn't publish eventually, but it was. And secondly, the statement that was made repeatedly that the PCR is the gold standard. It measures RNA, and that test is an antigen test, which is actually a different test. And the belief that was difficult to shake, that you were evaluating that flow test against an unevaluated PCR test that was self-stated as a gold standard, was stated by the media probably 10 times a week for 2 years, that without any justification for that. And that is quite interesting and quite destructive. I'm not saying that every test is marvelous, but the belief that PCR is the gold standard is impeccable is quite interesting. So I put that out because I suffered a lot from that and got very, very unpleasant abuse from various people that we were kidding people from using that for protesting. It was quite serious.
Could I just add a footnote to what Max has said, that the data might have been communicated a lot, but still there are different ways of communicating evidence and uncertainty, and that too requires evaluation along with the key messages that come out. And as most of us know, and that was talked about earlier today, different government departments have got their own communications groups. And one of the frustrations as a participant in SAGE, particularly SPI-B, was there was expertise there on communicating complex messages, and there was number 10 comms. So one had the scientific base for communication and the politics of it. So trying to work one's way through that, I think in the future, particularly for core messages, and we haven't addressed Tracy's question, which is about not knowing what the core aims were, but let's put that to one side for the moment. If one's clear about the core aims, then to actually be evaluating the different messages to see what proportion of the population are actually understanding those key messages. So that's another important part of evaluation.
And I think if I attempt to summarise our session, we've heard both actually the session before from the former minister, the need for there to be people within government working in the statistical service and so on, who are familiar and confident about experimental design, about how to design studies, how to design questionnaires, and the link between how you acquire data through to the analysis. And I think some of that needs to be revisited, and I hope that also in time, our journalist colleagues will consider that how you study a question, how you get the answer is as not more important, but as important as the answer that eventually you get. Because if the method of study is too contorted or confounded, you may actually get an incorrect answer. And so, but I think it's up to us as statisticians to try and speak for the cause of evaluation. But the way to do it effectively, as Max has pointed out, is that we need to be evaluation ready, and we need to work on that. And it's a good theme to work on, because between swine flu and coronavirus, there were draft protocols for cohort studies in intensive care units and so on, and the way to streamline permissions for randomized controlled trials of clinical interventions had all been set up. And so we need to learn as statisticians from this, that if we didn't have a big enough impact, it's because we haven't got evaluation ready approaches that can be useful to colleagues in policy and in the government statistical service. So I thank you all very much for your attendance, both personally and online, and I apologise for my somewhat haphazard sharing, but we're not too late, I hope, and I wish you all a very good evening. Thank you. I thank the RSS staff for rescuing me in various regards in this chairing capacity. Thank you so much, everyone. Thank you. Thank you.